Hi everybody, and welcome to my poster presentation on the effects of early hydroxyurea treatment on stroke risk in children with sickle cell disease. My name is Brian Peine. I'm a second-year medical student at Central Michigan College of Medicine, and I've been working with Dr. Michael Callaghan, who is a pediatric hematologist-oncologist at the Children's Hospital of Michigan. Sickle cell anemia disproportionately affects Black and Hispanic populations and is one of the most common causes of vaso-occlusive stroke in kids. As vaso-occlusion worsens in these patients, chronic blood transfusions are necessary to replace the hemoglobin S with hemoglobin A. But there are serious complications associated with long-term transfusion therapy, in addition to the high cost. These risks include iron overload, infection, and immuno-induced hemolysis, among others. Blood flow velocity through the middle cerebral artery has proven to be a fairly accurate indicator of stroke risk in children with sickle cell anemia, as higher velocity indicates narrowed cerebral blood vessels. This is measured by transcranial Doppler ultrasound, or TCD. Based on MCA velocity, stroke risk has been stratified into three categories. Lower velocities below 1.7 meters per second are considered normal. High velocities above 2 meters per second are considered abnormal and carry a higher risk of stroke, and velocities in between 1.7 and 2 meters per second are considered conditional. MCA velocity provides a good indication of how effective the current therapy is. Hydroxyurea, a chemotherapeutic drug, has also been shown to treat sickle cell disease by increasing the amount of fetal hemoglobin, and thereby reducing the proportion of hemoglobin S, which causes the sickling. However, there is a current gap in knowledge as to the potential long-term effects of prophylactic use of hydroxyurea in infants with sickle cell anemia. For our study, we performed a chart review looking at children with sickle cell anemia at the Children's Hospital of Michigan, who have had at least one transcranial Doppler ultrasound. We first compared blood velocities in the middle cerebral arteries by the treatment the patients were receiving at the time of their ultrasound, to confirm that hydroxyurea was indeed effective in reducing stroke risk, and also to compare hydroxyurea to chronic transfusion therapy. This relationship between hydroxyurea and a decreased vaso-occlusive events in sickle cell anemic children has already been documented in numerous prior studies. Additionally, for those patients who were receiving hydroxyurea treatment, we assessed MCA blood velocities by duration of hydroxyurea treatment at the time of the ultrasound. We wanted to see if long-term hydroxyurea use continued to be associated with continually decreasing stroke risk, or if this benefit was independent of treatment duration. So, of the three treatment groups that we looked at, including those receiving hydroxyurea, those receiving chronic transfusions, and those not receiving any treatment, our results showed that patients receiving hydroxyurea had the lowest MCA velocities, and therefore the lowest risk of stroke. And patients not receiving any treatment had the highest MCA velocities and therefore the highest risk of stroke. We were interested to find that patients receiving chronic transfusions displayed higher stroke risk than those taking hydroxyurea. So we propose that one possibility is that this may simply be because transfusion therapy is warranted in sicker patients, not necessarily that hydroxyurea is more effective than chronic transfusions. We therefore make no claim that hydroxyurea is more efficacious than chronic transfusions in decreasing MCA velocities, but hydroxyurea is certainly associated with lower stroke risk when compared to no treatment at all. Additionally, long-term duration of hydroxyurea treatment was associated with continually decreasing MCA velocities over the course of approximately 10 years, and the results were statistically significant. So here in the figure that I included on my poster, we can see that this is the course of 12 years here in the bottom, and that is the duration, not necessarily the age of the patient, but the duration of time that they've been taking hydroxyurea at the time of that specific ultrasound. So we see that over time, that mean velocity in the middle cerebral artery has been decreasing. Another way that we looked at this was we categorized these into year-long chunks, and with each year of patients taking hydroxyurea, that mean arterial velocity decreased. And the difference between 1 and 2 and even 3 years compared to 8 years or longer was statistically significant, and it was shown to reduce that mean velocity and also reduce the average risk of stroke in these patients. So along with that, many of the children with sickle cell anemia in our study began hydroxyurea treatment as infants, and our results indicate that prophylactic use of hydroxyurea is safe and is effective in reducing the risk of stroke. Given this association, we propose that initiating prophylactic hydroxyurea in infants with sickle cell anemia will increase the probability of maintaining MCA velocities in the normal range, which is below 1.7 meters per second, throughout childhood and adolescence, reducing their risk of acute stroke and dependence on chronic transfusion therapy. I've included some references here at the end if you would like to read more about the background of this, but I'd like to thank you all